Welcome, and thank you all for joining us during week 3 of Mental Health Awareness Month. The American Public Health Association's mental health section would like you to join us in this engaging conversation about addressing racial injustice through behavioral health, a theme we hope to highlight throughout the week. I'm Ali Rivera, the section secretary and communications co-chair, and I'll be moderating this event. A few housekeeping items before we begin. First, today's format for the event will include a roughly 25-minute presentation from our speakers, and the remainder of the time will be for Q&A at the end. Secondly, questions from the audience are highly encouraged throughout the presentation, so please feel free to drop them in the chat. And throughout the presentation, please remain on mute and off camera, but there will be an opportunity to present yourself on camera and to raise your question verbally if you so choose to during the Q&A portion of today's meeting. And now I have the pleasure of introducing our speakers. First, I'd like to welcome Dr. Ron Manderscheid. Dr. Manderscheid serves as the Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. The association represents county and local authorities in Washington, D.C., and provides a national program of technical assistance and support. Concurrently, he is Executive Director of the National Association of Rural Mental Health, adjunct professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, an adjunct professor of the School of Social Work at University of Southern California. Dr. Manderscheid serves on the boards of various councils and research institutes and serves as the co-chair of the Coalition for Whole Health. Throughout his career, he has emphasized and promoted peer and family concerns. Next, allow me to introduce Dr. Margaret Swarbrick, or Peggy. She is the new Associate Director of the Center of Alcohol and Substance Use Studies and a research professor in the Graduate School of Applied and Professional Psychology at Rutgers. Over her career, she has made significant contributions to the body of literature in occupational therapy, nursing, and community behavioral health care practice, focused on topics such as the 8 dimensions of wellness. She developed a strength-based 8-dimensional wellness model to promote recovery from mental health and substance use. Dr. Swarbrick is known for bringing the voices and needs of people to the table by collaborating with the peer community and family groups to identify and address social determinants that are barriers to recovery and wellness. And finally, Dr. Crystal Brando. She has been working in the fields of behavioral and community health for over a decade, including efforts related to well-being and wellness, trauma, healing and resilience, identity, culture and bias, and social justice. Dr. Brando is a senior professor, project associate, with Policy Research Associates, Inc., and the National Center for Youth Opportunity and Justice. Dr. Brando has a PhD in health communications from the University of Albany, New York. Her interests include broader interdisciplinary topics related to public health communication, population health, health disparities and equity, and media effects. Dr. Brando is also a section counselor for the APHA Mental Health Section, co-chair for the section's Population Health Work Group, and the section's web editor. She is a founding member of the Society for Health Communication and a consultant with Humankind Workshop and Inspired Vision, LLC. In her work, she focuses on healing, well-being, and racial equity, centering on the wellness-first approach. And now, without further ado, I will pass the mic to Dr. Manderscheid.
Thank you very much, and I want to thank the section for inviting me to participate. My role here today, I think, is setting the context for the comments that Dr. Brando and Dr. Swarbrick will be making. And I think the broadest context here is the fact that behavioral health has a huge role to play in addressing racial equity and racial justice. And it will be able to do that in a good way by working very closely with public health and working closely through the mental health section in the American Public Health Association and the broader activities of the American Public Health Association. So that's the context I want to bring. Now, let me put a little detail into that. So racial injustice is a very severe problem. It's obvious to every single person who's participating today that we've had a lot of difficulties with this in the United States. Most recently in police shootings, most recently in the Black Lives Matter movement, et cetera, that you've all participated in over the last year and a half. What we haven't really focused so much on is what does racial injustice do to the people who are subjected to it? So we know from research that racial injustice leads to trauma, it leads to behavioral health condition, it leads to other health conditions, and can even cause death. People who are subjected to very severe racial injustice actually have a high likelihood of dying 7 to 11 years younger than other people. And some of you will remember the research I did in behavioral health about 15 years ago that shows that public mental health clients die 25 years in advance. Well, about 15 of those years are due to the social determinants of health. Only 10 of those years are actually due to mental health per se. So there's an equivalency here. If you have severe mental illness, you have the same life expectancy as a person who has been subjected to severe racial trauma. So I think we want to keep that in mind as we talk about this problem. So then so the context in the mechanism here, severe racial injustice impacts upon people the same way that other social determinants do. How does that work? Social determinants lead to trauma. Trauma leads to behavioral health and health conditions. That then needs the invocation of treatment, rehab, and recovery, which we'll get into here. Now, how are we going to go about addressing racial injustice? So part of the bridging here between behavioral health and public health is to say we have to go back upstream to the social and physical determinants of health, and we have to deconstruct them. What do I mean by deconstruct them? We have to take them apart. We have to understand the power dynamics that are at play in the social determinants of health. You cannot understand racial injustice unless you understand power dynamics. Once you understand the power dynamics, you can then begin taking actions that will reduce the power differentials in systems. And systems I'm talking about here are all of the institutional structures in American society. The healthcare system, the behavioral health system, the educational system, the religious system, et cetera, all have these elements involved, and the social determinants in those systems need to be deconstructed. Let me give you one example. One example of this would be to ask the question, why do our urban schools lose 35% of their students before they ever graduate? And why are most of those students minority students? If you can answer that question, you then get into the issue of power dynamics in those schools. You get into issues of power dynamics in the classroom, et cetera, which you must deconstruct in order to do anything about. So that's the public health side of it. Then on the other side, moving to treatment and rehab, we need to have, in effect, trauma-informed treatments for people who've been subjected to racial injustice. And I think we in behavioral health are going to have to do some learning of the best way to actually do that. And ultimately, what we want to achieve here is rehabilitation and recovery. I always view recovery as helping a person regain their own voice. People who have severe behavioral health conditions actually have lost their voice. They've lost their voice among their friends, they've lost their jobs, they've lost their family, they've lost their place in the community. And part of recovery is regaining those various roles that are so essential to everyone. So what we're going to do today now is work our way down through this model and give some pointers that we hope will be helpful to people and actually be, number one, beginning to think about this, and then number two, beginning to do something about it. So thank you, and I'm going to turn it back over to Ali.
Thank you. And I think we are passing it back to Dr. Brando.
Thank you. If you don't mind, Ali, advancing to the next slide, please. These are two quotes that speak to what Dr. Manderscheid just shared. The first quote is by Dr. Ruth Shim, and it says, in our mental health system, people of color are overrepresented, misdiagnosed, and mistreated, and organized psychiatry has no plan to guide the correction of these well-studied and long-standing inequities. And the second quote here from Dr. Wendy Ellis, inequity itself is a driver of trauma. So this speaks to what Dr. Manderscheid just explained in detail and helps to further set the tone for what Dr. Swarbrick and I are going to dive into a little bit. So next slide, please. As Ron mentioned, our hope is that we can offer some material that will help folks begin to think about these things. We're going to dive into how to reduce the power dimensions within systems, but we're only really able to skim the surface of this in this conversation. This could be a multi-day, learning collaborative to really dive into these in great detail. So we hope that we'll be able to offer something that plants the seed for things that maybe you haven't thought about yet in your own life, your own personal experiences, your work, whatever role it is that you play as a stakeholder in topics related to behavioral health and racial justice. So what's on the slide here are two separate columns. One describes where we are currently with the behavioral health system, and the other describes where we could go to better serve the needs of people with behavioral health conditions and better support people of color with mental health conditions more broadly. So I'll dive into a few of these and then be handing it over to Dr. Swarbrick. And like Ali mentioned, please feel free to use the chat. So if anything is brought up that you'd like to talk more about or ask questions about, please feel free to use the chat box as we go through this. So one of the first items to point out here is, as far as where we are, the current systems that we have lead towards paternalism. In this sense, there's a dominant attitude that drives behavioral health care. The providers assume to know what's best. The provider is the expert, and this can fail to take into account the cultural preferences, needs, or values of individuals being served. We know that people with lived experience are the experts of their own lives, which makes this view of providers as being the experts in telling people the best course of treatment or action for them is problematic. Through this lens of social justice and health equity, one of the reasons that this paternalistic system is problematic is because of the lack of culturally diverse behavioral health providers. In the United States, we have a shortage of providers, mental health providers broadly in general, and this is even more specific for providers of color. In 2016, the American Psychological Association reported that 85% of providers across the country, percent of therapists specifically, 85% of therapists across the country are white. And therapists who identify as being Black, there were 4%, and Asian 5%. So this means that people of color are less likely to be able to access providers with shared cultural norms, values, and experiences. And while we desperately need more diverse providers, and we also need structures set up to facilitate this, like establishing scholarship funds and eliminating racism in the American Psychiatric Association, something we can also do is shift from these paternalistic systems to systems of self-directed care. This is a both and undertaking. And once we're in a system of self-directed care, individuals are empowered. Those individuals who are receiving services have opportunity to identify what supports their own mental health and recovery, what supports their own healing and their own well-being, and select the services that they most identify with, rather than being told from someone who, for communities of color, someone who may not have shared experiences, what those better services would be. Relatedly, shared decision-making is another more empowering person-centered approach to behavioral health. In treatment, for example, this current model, like Ron said, takes away from voice and choice of individuals, whereas systems of self-directed care can really support regaining voice and choice. So this is just one example of where we are and where we could go to better serve people of color and better support social justice. It's important to point out that these paternalistic systems that we have also empower white supremacy beliefs. To truly support regaining voice and choice in behavioral health, the systems that undermine these things would need to change. So early in this discussion, I want to point out that anyone can do white supremacy. White supremacy operates as a system of exploitation and a system of oppression. It's the ideology that whiteness is superior. For example, white epistemologies inform mental health treatment and diagnoses. We see this in Western psychiatry now and historically with the exclusion of people of color and the co-creation of meaning and of knowledge. And explicitly, this is also clear in the rejection of Black experiences, the mistreatment of Black people, and experimentation on Black people through Western medicine. So this can lead through oppression through behavioral health care. And again, anyone can uphold these beliefs, including people of color. This can be handed down, it can be learned. It contributes, however, to disproportionality, which Dr. Swarbrick will talk more about in just a moment. So there is a dire need in our behavioral health systems to dismantle white supremacy in order to reach social justice and health equity. And how we do this, there's a need to change policies, to change systems, to change resource allocations and practices to dismantle this. And again, we're talking about white supremacy as an ideology that contributes to systemic violence and structural racism. And so to regain that voice in behavioral health care and mental health care, the systems that silence those voices has to be eliminated to truly support recovery, healing, and well-being. White supremacy does operate many different ways. And again, in the interest of time, we can't dive into all of them. But one of the ways that white supremacy culture does operate is through an emphasis on individualism. We know that the current system is very much individualistic. This plays out where the individual is often treated for mental health conditions, say. However, a shift to collective action and collective well-being, community well-being is really necessary. While individuals do indeed have their own mental health that they're accountable for and take care of, there's a heavy emphasis in our society on individual responsibility as a central component of mental health recovery, and it's often not that simple. This fails to take into consideration community health. And if we think back to the zip code conversation, which is still prevalent and really kicked off several years ago, we know that zip code influences someone's physical health outcomes. And this sounds like new information to you. Please feel free to say so in the chat and we can provide some resources on this. But there's the data that proves that where you live impacts your physical health. And these same data also show that where you live impacts your mental health outcomes. So if we have this individualistic view of mental health, we're not accounting for this impact of place. Like Ron mentioned earlier, social determinants. If we're looking only at the individual and not the environment, we're not taking into account as a system social determinants, adverse community experiences, community trauma, and structural violence that's experienced by whole groups of people. So if we think of this time last year, for example, May 2020, following the murder of George Floyd, census data indicated that signs of clinical depression and clinical anxiety increased among Black people by 5% nationally. So that's an example of mental health outcomes being a collective experience. There was a traumatic event, collective trauma, community trauma that led to adverse mental health outcomes for people across the country. And so if we have this individualistic view of mental health, we're not able to fully bring in the experiences and the voices of whole communities. And so collective action and community well-being is a good place to shift. And the quote from Dr. Ellis that was mentioned earlier, she's at the Center for Community Resilience at George Washington, and they have a motto, Building Community Resilience, or BCR. And that's an example of how this can be done. It focuses on resilience as a strategy to prevent and reduce poor health outcomes by addressing the root causes of adversity. So as we continue to improve mental health and strive to improve mental health in this country, like Ron mentioned, there's this need to go upstream. We have to go upstream and investigate, identify, and transform or dismantle the power structures that are driving inequity. And so some of those include these white supremacy beliefs, paternalistic systems, and this focus on individual rather than community. And I'll hand it off to Peggy to cover the other items on this slide.
Great. And so, in terms of disproportionality and inequity that we see, I want us to think about in terms of the how, the when, the where, and who's designing and delivering services. There's major differences in the way people can access timely, quality treatment services, prevention services, treatment services, recovery support services when we think about the behavioral health. What we want to think about is it's the when, how, where, and who is delivering it. We're referencing what Crystal mentioned, who is providing it, people not being able to access a provider or services that represents the individual. I think that this is very, very rampant in our behavioral health system for years. Where it's offered and when it's offered, the timeliness and access for people is very impacted. So people are not necessarily getting timely access to quality services, treatment support, prevention, recovery support, whatever it is they need in a timely way, in a culturally attuned way. When it is, where it is, how it is. It's all very impacted by, and we're really seeing that one of the ways we can think about moving forward, where we could go, is getting more involvement in the decision making around the where is service available, who's designing it, getting more involvement of people in being able to divide it. This is really where the recovery supports, I think, can also really be an important piece in getting people with lived experience in terms of designing services, providing services, being able to understand that sometimes when programs are open or not open, it maybe needs to be rethought about what in terms of getting people better access. So we want to think about that. And again, related to the issues of trauma that has been historic on the individual level, the community level, there's so much trauma that's been mentioned already in terms of racial injustice, racism that people are bringing to that is affecting them, affecting their mind, their body, their spirit. It's affecting people in a profound way. And the way services are designed, delivered currently doesn't always take into account this. So there's not, though, when we think about the what's offered, doesn't always, the person's not able to access something that's going to be helpful for them to work through their challenge, but also recognize that trauma. And many times we see often the type, where and how and services being delivered provide re-traumatization experience for the individual. So sometimes we wonder, why are people not coming and knocking at the door and receiving services? Well, I've heard over and over that it's the way services often are delivered and designed can be re-traumatizing for people. So we have, in terms of ways we can think through this inequity and think through the many facets of trauma that is impacting people's mental health, behavioral health, substance use, mental health, thinking more about involving people in the decision making and thinking about activating cultural activation, thinking through, are we attuning to what people need and really listening and engaging with people to be able to make sure what is offered, how it's offered, when it's offered, where it's offered, who's offering it. There's some rethinking of that and redesigning and reshaping the way we offer services, or it's made available in a way. And thinking through and paying a close attention to the policies. Lots of policies can be influencing and re-traumatizing people or producing this inequities, rethinking the policies. But I really think what I really feel is important is practices, using practices that promote wellness, promote healing, a wellness first approach. We do have Crystal and I can reference a paper that hopefully should be out in psychiatric services that kind of maps out some of this. I know we don't have a lot of time today, but we want to highlight the wellness first approach, really working through seeing people physical, spiritual, social, emotional, intellectual, occupational, and environmental holistically, going back, helping use that self-directed care, that strength-based approach, and help people to think through using more of a wellness focused healing environments, that our treatment services are in healing in those environments, and how we're delivering our healing focus. So I think I know with timing, I think we wanted to take questions next. But I'm just looking at the time, and we had a bunch of questions come through, so I didn't know if we should just pause for that.
I think it's up to you all. Crystal, were you going to wrap us up on the next slide, or?
Yeah, why don't we, the next slide has contact information, because again, this was originally about 25 minutes of what feels like very rapid discussion, followed by some Q&A. And so we'll go through some of the questions that are coming in, and also make sure you all have our contact information, so you can feel free to reach out to any of us following today's session. The conversation does not have to end here at all. So I think getting into questions now would be great. And I see some folks are using the chat. That's wonderful. And if you would prefer to speak and use your voice rather than type, you can feel free to raise your hand, and Allie will call on you and unmute you if you want to turn your camera on and actually ask a question or share an experience, or engage in this conversation in a way that works for you. And I don't mind Allie diving right into the two in the chat box.
Sure.
One of the questions here, I'm going to give one part of it to Ron, and it's a question about the need to establish self-directed care systems as a response to paternalistic systems. So Ron, do you mind diving in a little bit deeper into the transition from paternalism to self-directed care?
Yes, of course. Thank you very much. So I guess the context on this comment is the fact that literally until the time when we had the Affordable Care Act in 2010, we had a very paternalistic behavioral health system. Doctor knows best. Doctor knows which meds you should have. Doctor knows which therapy you should have, how long the therapy should be, and so on. With the Affordable Care Act, where we moved from, I'm going to call it a more traditional disease-oriented focus to person-oriented care, it became obvious that in looking at person-oriented care, it became essential to talk to people, to have them become engaged in the delivery of their own care, and so on. And this has now burgeoned to the point where we can actually talk about self-determination in care and self-direction in life, actually. And these things have become very important to various people in our community who suffer very severely from these disorders. And actually, the Administration on Community Living is funding a center on self-directed care. And I happen to be on the board of that group and have heard first-person accounts of consumers who literally would say, I would be dead right now if it were not for self-directed care. Now, one part of the answer. Another part of the answer here is, how do you reconcile self-directed care with the issue of individualism that we also talked about? Well, I think in our concept of individualism that we were talking about, what we're meaning by that is the fact that everybody is, from the youngest age, is taught that everything you do is due to your own efforts. So, you were successful at baseball, you were successful in school, you were successful in the job or whatever because of you. There's no credit given to your family, the community, your friends, and so on in this process. And that's historically been the nature of American culture. In a certain sense, that individualism is very unhealthy for people because it doesn't allow the linkage between the person and the family or the community or the friends that they need to have in order to have a fully developed sense of self and so on. So I don't see any incompatibility between the concept of individualism that we talked about and self-directed care. long-winded answer here. I'll stop.
Thank you for that, Ron. I'll add for the individualism comment, if we think of physical health, for example, if someone goes to the primary care physician and maybe they're looking to change their eating habits to become healthier because they're at risk of chronic diseases, there might be questions about, have you been drinking enough water, eating fruits and vegetables, things about one's individual behavior, rather than questions of how easy is it to get fresh fruits and vegetables in your community? How is the water quality in your community to be able to drink water? Or do you have to buy bottled water? Do you have the funds to buy bottled water? So there are these other considerations, to Ron's point, where one does not necessarily just have an outcome because of that individual alone, but we have these factors. If we look from a public health perspective at the social ecological model, for example, of all of the various spheres of influence, and if we look at, again, social determinants of health, if we look at adverse community experiences, and again, these data on the increases of depression and anxiety, not only because of racial injustice in this country, but also as a result of the pandemic and the disproportionate impact of that, we see that somebody may be doing their best to follow treatment protocol or take care of themselves. However, these outside influences still matter, and there's not enough discussion about the environment in these contexts. So that's the emphasis on the individualism and one's sole responsibility for themselves being problematic, because that's not how things operate. So thank you for that question. Peggy, did you want to add anything there?
No, I think you guys covered it. I think there's another one. How important do you think it is for white leaders to address the ways they have been conditioned to inadvertently support structural racism?
Absolutely. I'll jump in and say I think that's absolutely important. I think if we look at the ways in which paternalism operates, patriarchy operates, white supremacy operate, there is value to doing self-reflection, organizational reflection, depending on the environment with which this question is coming from, or about whom it relates. Being able to look and reflect on what are some of the characteristics of these things and how do these operate in our work. Peggy mentioned, how policies can be re-traumatizing. Something that could be a paternalistic policy related to behavioral health treatment can actually be re-traumatizing. So how can those policies and practices be analyzed? Doing something like a disparity impact analysis on policies within an organization, within a behavioral health setting, can help with this introspection. And if there is this inadvertent support of structural racism, identify where those exist and create the change. Peggy or Ron, do you want to add anything there?
I guess the one thing I would add on structural racism is that for the most part, people who are in systems that exhibit structural racism may not be conscious of this. And it may be very important to actually have dialogues, to hear stories, to bring these things out into the open so that people in the system become aware that there actually is racial inequity going on in that system that people aren't consciously aware of. And there's a lot of that there's a lot of training going on right now in business organizations, in schools, and so on, to bring these things to the attention of people so that they can actually do something. But if you're not consciously aware of it, you won't assume anything's wrong or that you need to do anything.
Yeah, that's a great point. Thanks for adding that, Ron. Peggy, were you going to add something?
Yeah, and I think that's where we need to, that's a good way of moving it forward, is having that, having the confidence to keep doing that, because I think that it's why it's continued to prevail the way it had, the status quo. So I think it's speaking out, speaking up, and getting other involved others in who can take a fresh eye at it, take a fresh look at it, and making that a regular habit of allowing fresh eyes, and especially people who are impacted, giving that feedback and doing that on a regular basis, not just doing it now to check box because it's the thing to do today or tomorrow or next week, to make it part of our habit of doing that regularly on an ongoing basis.
Yeah, thank you for that, Peggy. I think too, a great part of that question is the use of the word conditioned. And that's important to point out, and it speaks to what Ron and Peggy just mentioned, that These things can be learned, and people may not be aware of the impact, aware that it's happening. And there's also the opportunity to do that internal self-reflection, organizational reflection, and bring in outsiders to conduct evaluations and analyses of workflow to be able to help identify these things that people may not be able to see themselves. And so if it's operating, it will be found, even if those engaged in it, are conditioned to not see it. There are ways to bring those things into awareness. Does anyone want to unmute and ask a question or share any thoughts about this conversation? Thank you for that comment, Mary.
Well, we'd love to hear your feedback on if there anything here was you need more information of what we've said, because we've kind of had a lot to say in a quick amount of time, or anything that just really struck at you that need further clarification or so. Again, Crystal will give our contact information. We actually have a paper that has a lot of this mapped out that should be coming out within psychiatric services, which we were a little glad to see that they accepted it. But I think that this is such important to be having these conversations and continuing them, and then us mobilizing ourselves to make the efforts. It's going to be a lot. It's a lot of work to do.
I guess I would add that, we want to thank the mental health section for hosting this session on racial equity, and hope that the section keeps at the process of working in the American Public Health Association to help address these issues and empower public health to take on the issue of racial inequity in all dimensions of public health, not simply in the behavioral health dimension. I think the mental health section can play a huge role in that.
Yes, absolutely. Absolutely. Thank you, everyone, for joining. And for those who are leaving some notes in the chat box, thank you. We're delighted everyone was able to log into this mini webinar today, 30 minutes to dive into some very detailed, intricate, challenging topics. So again, we hope that everyone was able to take a little bit away from this and again, plant some seeds. And I think Ron mentioning, having conversations with folks is huge. And that's something everyone can do. Engaging in dialogue, talking with community, and learning from people impacted by these systems about what can help improve outcomes, what can help with transformation, and hearing people, helping folks to regain that voice and that choice. So that's something that regardless of where you stand, that may be an opportunity for you. And if you are someone with your own lived experiences, feeling empowered to share that with others. So we thank you for joining. Allie, thank you so much for moderating and getting us set up. And again, a thanks to the section for highlighting this important conversation in week 3 of Mental Health Month. Thank you.
Okay, good.
Thank you all.
Good. Yeah.